Okay, thank you for introducing me. I will today talk about symptom score change and volume reduction of uterine fibroids with HIFU. I graduated Yonsei University Medical School, and I did my internship residency at Gangnam Severance Hospital and clinical fellowship in Aju University. And now I'm an outside professor of Samsung Medical Center, and I'm a founder of Choi Dong Women's Clinic. And actually, I did 2,125 cases of HIFU since 2015. It's my fifth year now doing this practice. Actually, I did one today, so it's 26. And Dr. Lee came to our clinic with Dr. Zhang at 2018, and we had many discussions about the HIFU treatment. It was a very good discussion. And Dr. Silva from Malaysia came to our clinic last year, and we also talked, and he observed a procedure with me. Coming back to our topic, the indications of HIFU in the field of gynecology is mostly uterine fibroids and adenomyosis, and there's some reports of endometriosis of the abdominal wall, and also retained placenta and tubal or coronal pregnancy. And today I will talk to you about the most treated disease, which is uterine fibroids. As you can see, this is a patient with total hysterectomy. You can see a well-demarcated mass here. It's a uterine fibroid about 5 centimeters here. And you can see an ill-defined enlarged uterus here. We call this usually adenomyosis. When we take the MRI image, you can see, you can compare a normal uterus with the uterine fibroid here. In a normal uterus, you can see the endometrium, the junctional zone, and the myometrium. But when you see a uterine fibroid, you can see a well-demarcated lesion like this. And the adenomyosis case, you can see hemorrhagic spots inside the endometrium and the widening of the junctional zone. Well, the symptoms of the uterine fibroids, we have mostly 3 major symptoms, many kinds of pains, many kinds of bleeding, and many kinds of mass effects. So the pain is dysmenorrhea, pelvic pain, back pain, so on. And bleeding can be menorrhagia, spotting, and the mass effects can be frequency by pressing the bladder or constipation by pressing the bowel. And we can have another, it's not a symptom, but a phenomenon that causes subfertility because of implantation disorder or uterine peristalsis disorders. As everybody knows, the uterine fibroid treatment options is operative and radiofrequency ablation and urinary artery embolization and HIFU, and there is some kinds of medical therapies. The principle of HIFU is, as this boy is doing, it is similar to making fire with a magnifying glass. HIFU is a focusing energy to a point, so the tumor is coagulated and necrotized. There's a transducer that forms the ultrasonic energy, and we gather to a point and point the focal point to the tumor like this. Actually, the focal point is very small. The width is 1.1 millimeter, and the depth is usually 3.3 milliliters. So we can make a very accurate ablation by this small focal point. We usually classify the HIFU systems by its guidance. There's an MR-guided HIFU, and there's a US guided HIFU. The energy source is all the same for these 2 kinds of HIFUs. Theoretically, the focal point makes the ablation point, and the points gather to make a line. and the line makes a slice, and slice makes a volume. But actually, a point is made, and then the gathered energy suddenly explodes to make a volume of necrosis. So we can see it by the sonographic findings as this hyperechoic lesions. Approvals of HIFU for uterine fibroids started at 2013 in Korea. The Korean FDA approved US-guided HIFU for uterine fibroids and adenomyosis. And on 2015, the US FDA approved MR-guided HIFU for women who wanted to maintain fertility. And on 2016, the KSUOG, the Korean Society of OBGYN, made a HIFU treatment guideline. So many physicians use this guideline to treat myomas for the HIFU. And on 2018, the KSUOG, the Korean Society of Ultrasound in OBGYN, published a textbook that deals HIFU for the first time. And as you know, 2019, the UK made a nice guidance for the US guided HIFU for uterine fibroids. This is the textbook that was published by the KSUOG on 2018. And the chapter 15 is US guided, US used in interventional procedures. And the HIFU chapter is in this. Actually, I wrote this part in this chapter. There's a principle here, and there's the method of the treatment, and there's many kind of cases. I deal about the cases and the complications and so on. And the US FDA on October 2015 broadened the use of MR-guided HIFU to women preserving fertility. And 2019 UK NICE guidance was published. The goal of HIFU is, in my opinion, there's two goals. The first is high volume reduction, and the second is high symptom relief. These two actually goes together. So if the volume reduction is high, we usually get more high symptom reliefs. To achieve this goal, the NPV ratio has to be more than 80%. I will tell you about the NPV later. So if the NPV ratio is over 80%, we get superior volume reduction. We usually can get 40 to 60% volume reduction in 6 months. And if the NPV ratio is over 80%, we can have superior clinical symptom improvement, usually 50 to 70% in 6 months. The NPV is non-perfusion volume, and usually means the necrotized volume. By NPV, we can evaluate the treated volume, and second, we can predict the therapeutic outcome. To check the NPV, we can use the ultrasound or the MRI. So we call it, when we use the ultrasound, we call it contrast enhanced ultrasound. We can calculate the perfused volume, and then we can calculate the non-perfusion volume to see how much was treated and ablated. This is the MRI finding. This is the contrast enhanced MRI. We can also see the myoma that is enhanced here before the HIFU, and just after HIFU, we can see the necrotized area, not enhanced like this. So compared to US CEUS, MRI is the best way to check NPV. CEUS may be convenient, but incorrect in evaluating the NPV, especially in large uterine fibroids or multiple uterine fibroids. And pre and post contrast enhanced MRI is recommended to check the immediate treatment results. And post 3 months to 6 months MRI is recommended to check the final result, which is volume reduction rate and residual volume. This is a image that appears in more than 80%. I think it's more than nearly 100% of necrotized lesion here. So very good result. You can also see a large myoma here. It was nearly all totally ablated. You can see a little bit of viable tissue on the margin like this. So if the MPV is more than 80%, we can think that the result, the therapeutic outcome will be very good. To evaluate the symptom change, we use the UFS-QOL, which is the uterine fibroid symptom and health-related quality of life questionnaire. This survey that was made in 2002 by ACOG to objectify subjective symptoms of uterine fibroids and to evaluate the efficacy of treatment. This questionnaire is composed of 8 questionnaires to check the symptom severity score and 29 questionnaires to check the health-related quality of life. This is the symptom severity score questionnaires. There are 8 questionnaires, and about 5 is related to the bleeding, 4 is related to the bleeding, and 1 is related to the pain or tightness or pressure, and 2 are related to the frequency urinary pattern, and 1 is feeling fatigue. And we check and make a score like this. And this is the health-related quality of life. We have 29 questionnaires here. I usually use this one to predict the results, symptom score change of previously and after the treatment. And we can calculate the score by this formula like this. It's just easy math. It's not difficult. I usually use the symptom score severity rate above 1. So high MPV is the most important thing, I think. So if the MPV is over 80%, we can predict a better symptom improvements. This picture shows you that if the MPV is more than 80%, the clinical success rate is higher. So for a high therapeutic outcome, MPV should be as much as possible, and we can predict more volume reduction and more symptom relief and lesser re-intervention rates. This patient had a submucosal myoma here. And after the treatment, after 7 months, it appeared like this tiny one here. The volume reduction rate was over 97%, and the symptom relief rate was about 80%. You can see the submucosal myoma here. The volume reduction was almost 50%, and the symptom relief rate was about 70%. You can see much of the necrotized area, but you can see some of the viable tissue here. So we have to follow up and see if it's growing or something. This patient has multiple myomas. We ablated each one like this. And then 7 months later, the volume reduction was about 41%. The symptom relief was about 71%. You can see this multiple huge myoma here. It exceeded the pelvic cavity. So we did the HIFU treatment. 4 months later, each myoma shrinked and the uterus went back inside the pelvic cavity. And 7 months later, it got smaller. So the volume reduction rate was about 70%, and the symptom relief rate was about 50%. So the conclusion, to achieve the goal, which is volume reduction and symptom relief, MPV is the is the most important thing. So we have to ablate as much as we can. At least 80% is suggested, and if we do this, we can get about 40 to 60% of volume reduction in 6 months, and about 50 to 70% of clinical symptom improvement in 6 months. Thank you. Thank you very much.